am very annoyed because I forgot to press record. It's okay, let's go again. Hi everyone, welcome back. My name's Sarah, I'm a junior doctor working near London, and in this video I want to tell you about a strange case that I saw working in the emergency department. Now, some of you might find this really weird, some of you might find this funny or even sad, but I think it's a case that A, is an interesting story, and B, has a lot of really key learning points to draw from. So let's get right into it. Let me just draw the scene to give you a better idea of the context. So it was around 9 p.m. I was doing a 1 to 10 p.m. shift, so it's the end of my shift. I was pretty tired, it had been a busy day, and usually when you get to an hour before the end of your shift, you try not to pick up another patient. So you finish off what needs to be done, because if you pick up another patient too late, then you'll probably have to hand over to somebody else. And whenever you hand over to someone, which basically means you pass on the jobs that need to be done and the management plan for the patient, there is always a risk of error, of missing things out. So it's always best to have continuity. Because it was 9 p.m. and the emergency department was pretty busy at that time, I thought I'd pick up another patient in any case and hoped that it would be a quick one. So I walk into the cubicle and I see a young lady, probably just younger than I am, so around 21, 22. She looks a bit sheepish and embarrassed, and she tells me that she's come in because she has a tampon stuck in her vagina. Now, at this point of my shift, I am already very tired and my brain isn't working as well as it was early in the morning. So I'm very aware of the fact that my brain is doing this and narrowing in on the problem that is presented to me. So as soon as she says that, initially I don't really question it, and I ask her for the story. So she tells me that she's on her period currently and that she uses tampons, usually changes them around 2 to 3 times a day, and that she had gotten one stuck in her vagina, that this had happened before, and that she was really embarrassed to be here, essentially. Now, if you know any basic female anatomy, you will know that the vagina is not an infinite dark black hole that you can lose tampons in. So I asked her if she was able to try and retrieve it herself, and she said that she had a go but couldn't find it. So the story sounds a bit odd at this point, especially when I start delving into it a little more, and I found out that actually this happened 2 to 3 days ago. And I asked her why she hasn't come in since and what she's been doing since then, and she just says that she forgot about it and is now embarrassed and has come in because she's worried that it's still stuck in her vagina. Now, based on her story, the first thing that comes into my mind of a life-threatening condition that I need to rule out is toxic shock syndrome. Now, this is a rare but life-threatening condition where you have bacteria that's introduced into the body. It's often associated with tampons, and that causes a release of harmful toxins. And your body has a very severe reaction to it. So you can have fevers, difficulty breathing, diarrhea, confusion, dizziness, lots of different symptoms, and it is very dangerous. So that's one thing to keep in mind at this point. I still took a full history, so a normal history you would take for anybody presenting with symptoms, with a sort of quick full body system checking respiratory, abdo, etc. But then also a gynecological history where you ask about different things like the menstrual cycle, any previous pregnancies, whether they're getting their cervical smears regularly. It's also very important to take a sexual history, so you ask whether they're sexually active, if they have a regular partner, how many partners they've had in the last 6 months, whether they've had any sexually transmitted infections, whether they use any contraceptives, etc. So she was sexually active, had a regular partner, and did not use any contraception whatsoever. The only positive symptom I got out of the history was that she had had dyspareunia, which is painful sex, in the last few weeks. So again, that's something that's important to keep in mind for your differentials. So for every patient, we still go through the same systematic steps, and that's taking a history, examining, doing your observations and investigations. So while I was going to get a speculum and forceps to try and retrieve said tampon, the nurse was doing some observations. They were all normal. She didn't have a temperature, which was reassuring. And we also sent off a blood test to make sure that there weren't any raised inflammatory markers or early signs of infection. For those of you who don't know, a speculum is a very strange looking object which essentially enables you to open up the walls of the vagina and be able to visualize the cervix, which is the opening of the uterus, and you can have a look to see whether there's any redness, whether there's any discharge, and if there's a tampon, you can locate the tampon. She'd had a speculum examination before, so I just explained the process again to her, and before I did that, I did a quick bimanual examination just to make sure that I couldn't locate the tampon myself and to feel whether there was any cervical tenderness. Now, cervical tenderness can be a sign of pelvic inflammatory disease. This is an infection of the upper genital tract, and it can be caused by things like sexually transmitted infections. It wasn't tender, and I could not locate a tampon, which made it very unlikely that I would be able to see it and retrieve it with a speculum examination. But because we need to be thorough and because there are other differentials that we need to consider, we then moved on to a speculum examination. Big surprise, we did not find a tampon, but what we did find was some cervical discharge. Now, I think you can come up with a differential based on the history we took with a painful sex and the examination with the cervical discharge. So at this point, I sat her down. I reassured her that there was no tampon stuck in her vagina, but we explained to her what we had found and that it was likely she had an infection, i.e. a sexually transmitted infection. When I told her this, she did not look surprised at all. It was more that she was relieved I had confirmed what she was afraid of. And that's when my tired brain realized that she had probably come in with the excuse of having a tampon stuck in her vagina just to be able to get checked out because she was worried about these symptoms. And that is why, my friends, it is very important to not just stick to the story you're told. So we gave her an intramuscular jab of antibiotics and advised her to book herself into a GUM clinic, which is a genitourinary medicine clinic. I think that's what it stands for. And essentially it's a sexual health clinic where you can go in and they will manage your treatment and make sure that they advise you accordingly to prevent this from happening further. We also highlighted the importance of her partner coming in for a treatment as well and advised her on barrier contraception to prevent sexually transmitted infection. So, learning points. I learned a lot from this case, and I think the three main points are: number one, trust your gut feeling. I think this is something that you definitely develop over time as you see more cases and with pattern recognition, but it's very important to pick that feeling when something doesn't feel right and to note it and do something about it. Number two, always be thorough in your history and your questioning. So this patient came in telling me she had a tampon stuck in her vagina. If I had just stuck to that story, I could have easily missed some of the other symptoms and other aspects of her history. So especially for a gynae presentation, you make sure you do a normal thorough history and then a gynae history, including a sexual history. And that's really, really important. In one of my previous videos, I talked about your list of differentials and how you always need to think of what are the most life-threatening things that I need to make sure I rule out. And you can only do that if you're thorough in your history and you ask those specific questions. Number three is to base your conclusions on findings that you actually have. So once you've taken a thorough history, you've done an examination, you've taken the observations, done the blood test, if you've done all these things thoroughly, all you need to do is put those pieces of the puzzle together and hopefully you form a much clearer picture, and that stops you from being skewed by your own assumptions or what the patient is telling you is wrong. Yes, the presenting complaint from the patient is important, but as you've just seen, sometimes patients will come in with one problem when actually they've got another more serious problem that they've come for. Or there might be some serious things that the patient doesn't even consider as important that will help you in your diagnosis. So make sure you do all those steps thoroughly and then put them all together to have a logical train of thought to your diagnosis. I hope you found this story interesting and that you were able to draw some lessons from it. If you enjoyed these videos, let me know in the comments down below. Don't forget to like and subscribe, and I will see you in the next video. Bye!